Welcome, everyone, to another episode of A Sister and Her Mister. Today we have Dr. Taz, a board certified medical doctor, integrative health expert, best selling author, and the powerhouse behind Center Spring MD. She has a holistic and integrative medical practice that she founded over 15 years ago.
Doctor said you got PCOS. Now go on, girl, just lose some weight. Till I took the symptoms into my own hands and reverse them naturally.
Thank you so much for joining us, Dr. Taz.
Welcome.
Oh, thrilled to be here. Thank you for having me. It's good to see you guys again.
Of course, and part of that description or introduction that we forgot to mention is Dr. Taz is also has multiple guest appearances on the podcast. So we really appreciate it. You brought so much wisdom and education on here. And we also heard recently that your own podcast, Whole Plus, also just received a Webby nomination. So really, that's amazing.
Congrats.
To be able to put that education out there and receive nominations for it. That's amazing. How do you feel about that accomplishment?
I mean, a little giddy, honestly, because, my vision for Whole Plus was to really provide a place where we can have good conversations about health and medicine, but we're bringing everybody together, right? I feel like a lot of the medical and the wellness community is very divided. Like you have a camp over here and a camp over there, especially in my medical world, right? And as an MD, I think people get kind of territorial about what they're talking about. And I really, wanted to create a podcast that was reflective of the practice. And in the practice, we bring medicine together. We, honor diet, lifestyle, spirituality, community, but we still talk science and we still go into the hard data. We're still making decisions moment to moment about whether this particular situation might need a prescription, or does it need an imaging study, or does it need herbs, or does it need acupuncture, and that's the art of medicine. It's been a joy. You said 15 years, and probably had another 5 of just studying and trying to figure it all out. But it's been a joy to see it come together, right? And so I think we want to tap into that collective experience and make sure, others are benefiting from it, even if they can't physically come into one of our clinics, but they're at least learning and growing. So we've had incredible guests, everybody from people, in the political space to the celebrity space to the, medicine, to like the true research and sciencey space to more of a spiritual space. And again, I'm just hoping the listener and the viewer is going on a journey of self-discovery and maybe getting one of those aha moments to really kind of spark their next step.
Oh, absolutely. Yeah, the episodes are really immersive. I think it's a really good introduction, or just for anyone who's looking to improve their health, those podcasts are a great way to get into that and then move further down the line with, being more proactive about their health. So it's amazing.
Such a positive resource for women who are, often so confused about their body and hormone health.
Yeah, definitely. And we tackle hormone health for sure, but this time I've expanded the podcast really to tackle all of it. So, because it's sort of a reflection of my own evolution. Like I think, when we talked last, it was, I might have just done the Superwoman RX or even my latest book, The Hormone Shift, which was very female focused, very hormone focused. And as we've evolved and the practice has evolved, it's just understanding so much about the family and the unit of the family and how we're only as healthy as the people within our immediate proximity, right? And the practice does that. It now sees a huge amount of men and children and seniors and like just the whole, circle of life type thing. And so I wanted the podcast to speak to that, of how health is communal. It is not just an individual kind of pioneering journey. It's really a communal journey. And so that's been my transition personally. And I think it's been, I think I did this subconsciously. I don't think I sat and thought about it. I think it just kind of evolved. But now that I look back, I think that's exactly what's happened with the podcast. It's gone from like your individual health, female health, to communal health, and what we as a community, as a family, as a city, or as a country need to be thinking about.
I love
That's
that.
so interesting.
That's an amazing, just amazing a theme around the whole podcast and growth.
Yeah, definitely. Definitely.
And speaking of your practice, you now have 2 clinics, one in LA and another one in New York. Could you speak to what you do in the clinics in terms of helping others and what kind of conditions that people usually come in with?
Yes. Yeah, and we actually, not to brag, but we actually have 4 clinics, and we also have a
Oh,
virtual platform. We've got 2 in the Atlanta area, the telehealth platform, 1 in New York, 1 in LA.
amazing.
We've tried to really replicate, kind of the same methodology over and over again. So what people can expect is really a blending of all systems of medicine. So when you're coming in, our initial intake and kind of like our triage process is a lot of what you expect with, blood pressure, pulse, history, all that other stuff. But we are also doing evaluations of your meridians from a Chinese medicine perspective, looking at doshas from an Ayurvedic perspective, going into metabolic health and what those markers look like, getting into energetic medicine and energy medicine and energetic health a little bit with scans and frequency and vibrations. And again, bringing all of that together so that when we're charting a journey for you, for some people, they need to start with a relationship or stress. Other people need to start with, a hormone and balancing that hormone. Other people need to start with a diet change. So again, it's that starting point. I think that's somebody who's been in the space for a while now, I think for me, when I pull back and look out, it's like, it's just so noisy. I mean,
Hmm.
it's almost like I'm glad we're talking about everything, but in some ways, the consumer or the patient is almost more paralyzed because they're
Yeah.
getting super confused by like, well, this one said that, and that one said this, and all that other stuff. So the clinics,
It's
the
like
podcast,
overconsumption.
it's overconsumption. So it's all about personalization and really helping you figure you out so that you can move forward. And then hopefully you bring your family along for that ride.
I love that.
Yeah, that's incredible.
But I didn't
It's
answer your question. I'm so sorry. I didn't
oh
answer
no,
your
no, that
question.
was great. No, that you
Your
answered it.
question was about
Oh,
conditions. So the conditions, like if I had to rattle off conditions, it's, definitely metabolic health is a big one. Hormones and hormone balance is a huge one. PCOS, perimenopause, menopause, low testosterone, infertility, unfortunately, is a bigger one nowadays. We're
Mhm.
getting a lot. It's been, again, time. I'm dating myself, but the shift has been a lot of younger people coming through and asking or trying to inquire about autoimmune disease, even early cancer diagnoses and things like that. So it's condition based, but it's also primary care based. So some people just use this as their medical home.
Mhm.
right.
Yes.
How often do you see patients come in with PCOS or endometriosis, which I want to touch on with you?
Definitely. So I would say,
Mm.
and again, I'm going to siphon off the female population, it's probably in the 18, 17, we probably need to go younger, probably in the 15 to 32, 33 age group. It's probably 30-40% of the patients coming in. It's a pretty,
Wow.
and I don't know, I mean, I'd be curious to see what your perspective is. I just feel like I'm diagnosing it a lot, like over and over
Mhm.
again. And part of that, I think, is more awareness. Part of that, I think the guidelines have changed a little bit over the years, which is great. I think that's important, and we can talk about that
Oh
as
yeah,
well.
I'm curious. Like, have the guidelines been in a way where more people are being diagnosed, like in a positive way, or do you feel like it's maybe misdiagnosing too? Like, could you clarify that?
Yeah, I definitely. So I'm blanking on the year, but I want to say somewhere in 2019, maybe 2020, I don't remember the exact year, the guidelines for diagnosing PCOS were redefined, but they are not translating into the exam room. And the study that I have in my mind was fascinating because it actually looked at PCOS across ethnic groups and how there were different versions of PCOS depending on who you were talking about. So Caucasians had one version, people of Middle Eastern descent had a different version. The Southeast Asian community had a version. The African American community had a version. So there were different versions. The one thing that study did that I loved because it was a big part of my story of being missed, and misdiagnosed for probably, 8 years before I figured out what was going on with me, was that it didn't peg having cyst on your ovaries as a necessary diagnosis for PCOS. So the biggest myth and the biggest problem we still have today, because it's not translating down into the
Mhm.
exam room, is that many people will tell me, like, I don't have PCOS, I don't have cyst on my ovaries. But that doesn't mean you don't have PCOS.
Yeah.
And PCOS has been redefined as a metabolic disorder more so than
Yeah.
just a hormone disorder. So, what everyone needs to start really looking for, and clinicians need to start looking for, is the insulin resistance, right? And the insulin
Mhm.
sensitivity that is actually one of the foundational diagnostic criterias of PCOS, not just cyst on your ovaries. So I think that, that opened the door to us being able to identify more and more people, because I meet people all the time who don't have cysts, don't necessarily have high androgens. That's the other diagnostic criteria, right? Like high DHT, high free testosterone, high DHEAS, some of those type of things. But they have the insulin resistance, and you catch it by doing a fasting insulin level, putting a monitor on them and watching their blood sugars. There are a couple of other blood sugar, levels or labs that you can check and get the confirmation. But that insulin resistance is getting missed. As it goes on for a longer and longer period of time, it triggers inflammation. And then that inflammation looks different on everybody, depending on what your genetics are and your family history and that type of thing. But that inflammation in turn ends up contributing to diagnoses like PCOS and endometriosis. So, we can talk about all of that from a pure diagnostic standpoint, though. The guidelines were amended. They're just not being followed,
Mhm.
So when women have hormone issues, no matter which one, PCOS or endometriosis, or any of them, honestly, we need to make routine testing of blood sugar and routine testing of insulin a part of that workup, because then we're going to be better able to define and identify, first of all, at-risk women, but secondly, that part of the physiology, that's off, that is really preventing people from getting results.
Yeah.
Yeah.
Checking for insulin resistance is different than checking your glucose levels or your A1C. And I feel like a lot of times people don't have that insulin resistance factor checked. They're like, well, my glucose was fine and my A1C was like kind of high.
Right.
But that like if your A1C is high or your glucose is high, that could be late signs of insulin resistance. And even the slightest bit of insulin resistance can create PCOS symptoms. So I totally agree with you that that needs to be like vigorously tested when someone comes in with irregular periods and cystic acne and hair loss and all these signs and symptoms of
Definitely.
PCOS. It's
Definitely.
totally just glossed over.
Yeah, I mean, people push back on, even on the monitor. I don't know if either of you have ever worn a glucose monitor before, but even on the monitor, they're like, it's normal. It's like, look, it's normal. But normal on a monitor is not okay for a lot of people. You really want the monitor to be somewhere between 70 and 90. If you're spiking up into the 110s and the 120s,
Yeah.
that tells me that you're kind of hovering in that world a little bit, and it
Yeah.
needs further exploration. So just remember, normal, and you guys know this, but normal and conventional medicine is about not having a disease. Normal is not about being optimal and having optimal hormone function or optimal,
Mhm.
fertility or things like that. So there is a difference between the two.
Yes.
Totally.
Yes.
Yeah, we always suggest seeing a naturopathic doctor, someone who studied functional medicine, to really deep dive into lab work, because the conventional lab ranges are so broad and vague.
Right.
And
Yeah.
Yeah, definitely.
The diagnostic criteria still blows my mind, because the first year I was learning about PCOS, I immediately knew about the Rotterdam criteria and that you don't have to have ovarian cysts to be diagnosed.
Right.
But that, myth or that misconception still continues to this day, which is so unbelievable, especially like when doctors just, like you said, like you do proper lab work, you do all the proper checking so that there's no guesswork in the beginning. But still to this day, there are some who are unfortunately just giving out the birth control without looking at the proper lab work to really see, do you need the birth control, or should we
yeah,
focus on these other
Yeah.
natural solutions first? So,
So true.
Yeah.
So true.
totally. Another myth is if you're not overweight, then you don't have PCOS. And that's
Right.
so
Oh my
untrue.
gosh.
You could be so insulin resistant and have lean PCOS and not
Yeah.
be overweight.
Yeah, definitely. It's almost like in the menopause community where people are not overweight but have fatty liver, so it's
Yeah.
all about
Mhm.
what your blood glucose is doing, how the liver is working with it, and what that looks like. So weight too, you're absolutely right. It's
Yeah.
again, I don't think anyone should rely on one indicator to say, I don't have this disease. Absolutely.
Right.
Mhm.
Just should not do that,
Correct. Yeah.
should really have, again, that holistic approach, right? Looking at things from different angles and then putting the puzzle together, to
Mhm.
understand it.
Yeah. And then you had mentioned that we want to, of course, move on to endometriosis and
Yeah.
comparing the two. But I was really curious when you said that you see that from different ethnicity groups, that they can have different types of PCOS or different,
Oh, I was gonna say that too. I forgot. Yeah.
Yeah, I'm really curious to hear, like for example, let's say someone like
Middle
we're
Eastern.
Middle Eastern
Middle Eastern.
versus someone who may be, from America, or like from, let's say, who is European. Like, do you think the PCOS might differ in how those symptoms come out, or what symptoms flare up?
Yeah, and again, these are broad generalizations because, I know everybody has a unique story, but in general, those of Middle Eastern, where are you guys from? Out of curiosity.
Armenia.
We're
Armenia. Okay.
Armenian, but our grandparents and great grandparents were born in Turkey.
In Turkey. Okay. So I have a little bit of that, but definitely the Indian part, we are a little bit mixed up. So we've got a little bit of the Middle Eastern, and then we've got, definitely the Indian. Our populations have a real huge problem with the androgens. They tend to be androgenic populations. So meaning,
Warriors.
yeah, exactly. So when things go haywire, it's more testosterone, more free testosterone, more DHT. Oh my gosh, you're making me laugh because my husband gives me a really hard time. He's like, "Why did I marry you? Everybody in this family rages."
That's so true. Sina calls me a category 10 hurricane on like holidays.
Yeah.
I know. And
It's like
he's
Christmas, I'm like everywhere doing everything. It's like, she's a category 10.
I know. And he's from a warrior background too. So it's like, I don't know how this happened. It probably wasn't best for our kids because, everyone's like through the roof on everything. But, all jokes aside, but that is an androgenic population is probably the best way to think about it. So the acne, the hair loss, the facial hair, right? That typically is the primary driver that shows up in different circumstances, whether you're super stressed or the diet's off or the environment or all those different things. I think for the African American community, they have a huge issue with the insulin resistance component that then drives the other stuff. So they're going this way when, we kind of look at that part of the equation. I think the Caucasian community has a little bit of a different story. I think they have more issues with general inflammation and issues, with sort of the gut microbiome, those type of things that then in turn drive it. So it's interesting to see how different pockets, present. Ultimately, everybody kind of converges in this pattern of insulin resistance, high androgens, maybe estrogen dominance, all that stuff. Everyone kind of converges there. But the primary is really important because if you can identify the primary, you can build a protocol that's not overwhelming, right? A lot of these protocols just seem so overwhelming. So the goal is to build a really efficient, kind of clear protocol to target the main driver. And as I wrote about in the hormone shift, one hormone is like a domino. It impacts everybody else. If you can kind of fix that primary driver, you have less to do on the downstream.
Oh yeah.
Well, this was very
I love that.
and reflection.
Yep.
I'm never gonna hear the end of it from you.
But it makes so much sense because like depending on where you're from, there's genetics at play. So what's going to flare up, but also like, your environmental and your cultural factors from your region too. Because like in America, for example, we have so many inflammatory food. People here are way more gluten sensitive than they are outside of the U.S. due to the process that the gluten goes here. So it's like inflammation, poor gut health is just like running rampant in America, unfortunately. So that's just gonna inflame those symptoms a lot more. So it makes a lot of sense.
Well, it's like a switch, right? I think there is a switch that gets turned on, and it can get turned on at different points in life, from the time you're, a teenager or so all the way into postmenopause. I mean, I remember landing in India, meeting my relatives for the first time. They were huge. I don't know if I've told you guys the story before. Huge, and I was just like, my face, and my poor mom worked really hard on diet and nutrition. She was very much into all of this and managed to keep herself at a good weight. None of us are like super thin, but like at a healthy weight, and they were just a different dimension. So now growing, now that I know this field, I think they suffered from it, in a perimenopause, menopause timeframe. They also lost their hair. The majority of the women lost their hair. So as the hormones went downward, they expressed those high androgens. I don't know what their story was when they were younger, but in our family, from my 17-year-old daughter to my now 70-year-old mom, everyone has some level of androgen expression. Everybody. Some are severe, some are not so severe, but everybody has something, so it's super interesting.
Yeah.
Even if for me, not to I really want to get to the endometriosis.
We're doing this. That's
the
okay.
labs, look, I have had extensive labs done. Everything's fine, even the testosterone levels. And the truth is that the testosterone receptors, are more sensitive. So even if I'm a little stressed or I have some sugar, it just
flares up.
it's like there's no mercy.
Because yours is like more sensitive than
it's just sensitive. It just is what it is.
Mm-hmm.
Yeah. And that's what we see a lot of in our population for sure, you know.
Wow.
Yeah, for sure.
Well, okay. Let's get into the endometriosis and PCOS. So,
Yeah.
what are the key differences between the two when it comes to symptoms and root cause, and how do they show up in our bodies?
Definitely. So, first of all, they're sisters, is what I always call them. Oftentimes they coexist together. So, you'll find PCOS, but you'll also find endometriosis. So, anytime I'm diagnosing that, I'm kind of also thinking about endometriosis at the same time. I think while PCOS, we've done a better job at diagnostics and trying to tease it out, at least in terms of awareness. We still have kind of a ways to go with endometriosis. I still feel like it's hard to diagnose, it's hard to nail. Endometriosis, just from a pure definition standpoint, is overgrowth of the endometrial lining, right? So first it begins kind of in the uterus or in the walls there, but then it can outgrow and grow onto the intestines, into the rectal area, down, even down into the cervix. So the biggest difference when I'm taking a history is listening for symptoms of pain, you know, but not just menstrual pain. That's not enough for that to flag in my mind. It's pain with bowel movements, you know, pain with motion in general. Diffuse body pain often goes with endometriosis, because one of the big things, hallmarks about endometriosis, is that it is a disease of inflammation for sure. It's not necessarily a hormone disease. So you'll see more diffuse inflammation in many of these patients. In fact, I think there's a big overlap between fibromyalgia, other autoimmune diseases, and endometriosis. So with endometriosis, we will see more consistent pain with bowel movements, especially around the time of the period. To me, that's an instant light bulb going off. We'll see things like pelvic congestion syndrome, meaning when somebody is standing for a period of time, they start to pull, they'll get some leg heaviness, some leg swelling. Some will have pain even with sitting if they're like clamping on a particular artery in a way that they're doing so. But those are symptoms historically. When you're thinking about circulation, when you're thinking about the pelvic floor itself, pain with sex, all of that is more endometriosis than PCOS. Maybe the only good thing about PCOS is that it is fairly limited in terms of its symptoms to around the over, like in terms of just pain, to the menstrual time frame, right? Like when you're about to get your period or after your period or at ovulation, but you can time those things. Endometriosis, on the other hand, seems to be more systemic. You know, you have pain all the time. Many of your symptoms are showing up constantly, except they intensify maybe as your period approaches or even if you get your period at all. And when we think about root cause, you know, again, they share a lot of similar causes. So you mentioned the gut microbiome, you mentioned inflammation. Those are consistent with both endometriosis and with PCOS. But the big differentiator for endometriosis is that is historically a pattern of estrogen dominance. It's not usually 20 different hormone patterns that we're trying to sort through like we are with PCOS. It is always estrogen dominance, and maybe there are a few others involved, but that's typically the primary. And the estrogen dominance, you know, once you start having a conversation about that, you know, that's everything from genetics. Like some people, I have COMT, where it's just hard to break estrogen down. Some people have MTHFR. There's another alphabet soup called CYP1B1, which is again difficulty breaking estrogen down. So they have the genetics, but it's always a three-hit theory for any of these autoimmune diseases. So the genetics could be one, but then maybe they were super stressed. And when you're stressed with cortisol, that in turn leads you down a path of estrogen dominance for certain groups. Then, you know, maybe it's not stress, you know, we're just dumping everything on stress, but it could be, you know, exogenous estrogens in our environment, on our body care, our home care, you know, the things we're taking in, you know, all of those things, those can trigger estrogen dominance as well, you know, or is sort of, and I guess that's tied, but so that gets you tied back to liver toxicity, where the liver is not able to do its job because it's so busy fighting off all this other stuff. So you're converting over into these estrogen metabolites that in the wrong genetics are leading to estrogen dominance. So then you have a soup almost. You have estrogen dominance, you have inflammation, and then maybe you have a genetic predisposition. And so those are primed conditions for developing endometriosis. But the saddest part of it, it goes undiagnosed for, I think studies say for up to a decade. You can have
Wow.
undiagnosed
Wow.
endometriosis.
Is that because it's like mild at first and it gets progressively worse? That's why it's not
Oh,
as, I see.
and sometimes you don't have the pain, but it's like happening inside.
It's there, right. And the
Yeah.
other problem is you can't see it. Like you can't
Yeah.
see it on an ultrasound necessarily or a CT scan. You can get a clue. So I'm having most of my patients do pelvic ultrasounds. I think all women should be doing that yearly, period, even our teenagers. And so if you start to see that endometrial lining thicken up, it's going past about 6 or 7 centimeters or so, then you know that that person also has risk factors for endometriosis. So that's one way you can tell on a diagnostic study. You can look at hormone metabolites, and if you've got like high estrogen or high 4-methoxyestrogens, again, a clue that this might be an issue. The gold standard in medicine is to do a laparoscopy, which is a
Yeah.
surgery to go in and look for it, right? So that's the other like kind of barrier, because so many of us are going to be like, I don't want to do that unless I'm miserable. So you're waiting until you're super miserable or you can't get pregnant or something along those lines before you do that study. More recently, there's been some reporting around using general inflammation markers, which we do, like a CRP, a sed rate, a homocysteine, all that other stuff, but also using a CA-125. And CA-125s historically were used to detect cancer, but when they are elevated, you can use it as a screening tool for endometriosis as well. So again, it's kind of stitching these puzzle pieces together. Like if you got a thickened endometrium, if you got a high CA-125, if you have high inflammation markers, a lot of diffuse pelvic pain and pelvic type symptoms without a clear diagnosis, you should be thinking about endometriosis, which at the end of the day, it's almost like I would think of both PCOS and endometriosis as autoimmune disorders. I mean, I really would kind of be thinking about it that way. So then when you're trying to unwind that, you want to deal with the hormone pattern, you want to deal with the inflammation, right? And then you want to go on a journey of like, what was my primary trigger? Was it the food
Mhm.
I ate? Is it a product I'm using? Is it my genetics? Is it trauma or stress? Because we now know that those things do trigger estrogen dominance as well. What specifically did it? So again, dividing the two, PCOS a little bit more localized and timed or cyclical in terms of symptomology and pain, more focused, I would say, on maybe ovarian health and multiple different hormone patterns that go with it. Endometriosis, a little bit more diffuse, meaning all over the body when it comes to pain or symptomology, inflammation being kind of the strongest one, and a lot of like very subtle, secret, hidden pelvic symptoms. I think it's important for women to be aware of that. And then more of truly an inflammatory disorder with estrogen dominance as its main driver.
Mhm.
So that's kind of
Mhm.
how I see the two. Now, when I'm working the two up, I will test all the hormones. I'm still testing every hormone, right? But when I'm thinking endometriosis, I order the pelvic ultrasound, I add a CA-125, I make sure I do inflammation markers, and that helps me with sort of like, okay, this is worth, that next step, of maybe they might need a laparoscopy.
Wow. Well, thank
Well,
you for that very thorough explanation
yeah.
and the summary of the two at the end too. And if you had a patient who had either PCOS or endometriosis, is there a form of treatment that you would give one and not the other, and vice versa? And also, do you find that there are similar treatments for the two that works for both?
Yes to both. So similar treatments, let's go there first. So a similar treatment for both is to, really work on the gut and work on the microbiome and get that balanced out. So really working on digestion, making sure they're not fat malabsorbing, making sure the liver has support. So a lot of times I'm doing things like digestive enzymes with meals, using things like milk thistle for more liver support or choline to really help the liver do its job. That's going to be important to both, right? So that's a commonality. When it comes to PCOS, though, again, as we were talking earlier, I'm trying to hyper focus on the dominant hormone pattern. And I write about this some in the hormone shift too, but each of us has a dominant hormone pattern. So some of those people in the PCOS world, that pattern may be estrogen dominance. But like we were just talking, for us, it's androgen dominance, right? For somebody else, it's insulin resistance. For somebody else, it's estrogen dominance. So PCOS, I'm having to tease out the primary pattern before I start a fancy protocol on them. And, you know, the universal with PCOS from a dietary standpoint is eating for blood sugar, you know, like eating every 4 hours, trying to keep that blood sugar nice and stable, getting the right amount of protein and fiber and fat. So, you know, we're not doing the ups and downs of blood sugar. Whereas with endometriosis, I'm treating and thinking for estrogen dominance and inflammation, which means essentially that yes, I want to support the liver and yes, I want to support the gut, but I specifically want to help estrogen break down. So it means I may add something called DIM, which helps to break estrogen down more effectively. And a patient, you know, sometimes patients come in and their levels are through the roof when it comes to estrogen. We may step it up a little bit and add calcium glucarate. And calcium glucarate is incredibly effective at estrogen metabolism, but it does drop it. So sometimes my patients will start to get like hot flashes and I'm like, okay, it's too much. You know, we need to move this to like 3 times a week or something along those lines.
Mhm.
And then we'll pair that with a plan for inflammation, you know, and so the plan for inflammation is around diet again, cleaning up and, you know, not getting inflammatory foods. That's more of the focus with endometriosis. And then adding things in like a black seed oil or turmeric or something called LDN, low dose
Oh,
naltrexone,
yeah.
that helps to bring the inflammatory response down so that as you work on the hormone, you're bringing the inflammatory response down, and the combination of the two can stop the overgrowth of endometrial tissue, you know. So that's the
Interesting.
main difference between the two, you know.
Yeah, amazing. Thank you for that explanation. We've heard of LDN recently being used for like autoimmune
Oh
conditions and
yeah.
for high inflammatory markers. So that is a something we've actually been hearing a lot more in the last few months.
Even thyroid disorders.
Yeah.
Totally. We've been using it for years. I mean, probably of the 15 years, we probably started it, you know, at year 12, you know, but we've been using it for autoimmune disease, for Hashimoto's, for sometimes not as much for PCOS, but definitely for endometriosis for sure. There's
It's
just,
for it's for reducing inflammation.
And
it's
like
for
autoimmune
reducing
conditions.
inflammation.
Yeah.
I always say it acts like a prednisone without the prednisone, you know, kind of side effects and all that stuff, but a game changer for many people, for sure.
Interesting. So alongside like Synthroid, you would take low dose naltrexone to
Yes,
reduce inflammation.
absolutely.
Mm.
Absolutely. And then we would monitor it by, again, those inflammation markers. But in the case of Hashimoto's, looking at the antibody load too.
Mhm.
So,
Interesting. One thing that I did learn a while ago, and I want to get your take on it, is sometimes when people have PCOS and then they don't know that they have endometriosis, and then they start treating the PCOS and getting their testosterone under control, it starts to go down, then their estrogen starts to seem more elevated in comparison to the other hormones because their testosterone's going down. And they find that their endometriosis starts to flare up.
hmm.
Some type of, like, strange shift happens. Is this something you've heard of before? I've heard it once before, and I wanted to ask you that for anyone who's listening, who's managing PCOS and then finding that other symptoms are flaring up.
So typically, if you're, and I would question how that PCOS is being managed, because if you are managing PCOS with sort of like a more holistic or functional strategy, that shouldn't really be happening.
Mm,
But on the other hand, if you are managing it with like a spironolactone, right, or an androgen blocker,
right.
well, we can see things like estrogen dominance as sort of kind of like a fallout from being on that androgen blocker. That's where I go back to. I feel like I've been beating the drum for a while now, but it's really important to test your hormone levels. Really
Mhm.
important.
Like once a year, right?
Once minimal, you know, for anyone with issues, I would say twice, you know,
Yeah.
just to get a sense of what's going on. But, you know, there's a lot of pushback on that. There's a lot of like, well, I have a cycle. How do you interpret them? You know, do I have to do a Dutch test or a big saliva test every time? The answer is no. When you do lab testing, we have a whole kind of guide in the hormone shift of like roughly where levels should be, no matter where you are in your cycle. There's some absolute highs and there's some absolute lows that women should not be crossing, really. And if you're starting to cross those, then it should make you suspicious that you are at risk for this particular hormone pattern. So let's say you start spironolactone, which some of my patients, to be 100% honest, are on, because we've done all the other stuff and they need to be on something. But the beauty is, instead of being on 100 or 200 milligrams, they can get away with 12.5 milligrams, but they needed just something. But let's say you go on one of the bigger doses of these medications, but you're not managing the gut, you're not managing the liver, you're not managing the other hormones, whether it's thyroid or cortisol or insulin. You're still going to get estrogen dominance, even though you put a Band-Aid on the testosterone, right? So I think when you don't think, for that person dealing with that, I would say that it's probably not being managed holistically. When you manage holistically, it works in tandem. So you don't do one thing that causes a problem, somewhere else. That would be my sense there.
Okay,
Yeah.
that makes sense. That makes sense. Well, then okay, we talked about treatment, we talked about diagnosis and differentiating the two.
Yeah.
Are there any other questions that we didn't cover about PCOS and endometriosis?
I think at one point we talked about supplements as well. Is there anything, Dr. Taz, you would like to add in terms of the confusion behind PCOS and endometriosis and how to help people clarify the difference, or if they have both?
Definitely. I mean, I think one of the big things for even our young girls, because I'm looking at my daughter and her friend group and all that other stuff, but and they're teenagers, is I think if you're having chronic pelvic pain, that needs to be investigated. And many girls do. And then if you are having chronic abdominal pain, right, if your GI system is disrupted, that's a higher risk for endometriosis down the road. So I would encourage anyone who's having like unexplained constipation or diarrhea, or again, we talked about like pain with sex or just general lower pelvic pain, to get checked out for endometriosis and to start that journey of trying to figure out if that's what they're going through. With PCOS, again, just remember that it is a little bit more cyclical, and it is something that maybe isn't consistently there. And I think it's important to know that differentiator, but many women have both, and so the two are very interrelated together.
Yeah. Pelvic ultrasound is something I learned today. It's basically do it every 6 months, every year, just do it, because you never know.
January. Check for
Yeah, I mean, I've timed mine around my birthday, but I would do labs. I think all women, all girls, labs once or twice a year for your hormones, pelvic ultrasound yearly, just to look at that endometrial lining, look at the ovaries, what's going on, and then you can game plan from there.
Yeah.
Well, thank you so much for all of this information. I'm sure everyone who's listening feels so well informed about endometriosis and PCOS.
And we're gonna link everything in the podcast description as well, so people can find your practice as well as read your previous books. And everything about your podcast as well, Whole Plus, all of that will be in the description of the podcast. So we highly recommend everyone to check those out too.
Yes. Thank you so much for joining us, Dr. Taz.
Yeah,
thank you. This is fun. It's good to see you guys again.
Good to see you.
Take care.
Bye.